My next guest is Dr. Thomas Lee. He's founder and CEO of Galileo Health, a membership program that leverages technology to connect patients with doctors. Before launching Galileo, Dr. Lee helped create One Medical, another membership-based primary care platform. I spoke with Dr. Lee just a short while ago. It's a cool conversation. Take a listen.
Dr. Lee, thank you so much for joining us today. Look, I guess as I think about when the internet and broadband got widely consumed in American society, global society, and really began to change the way we saw our interaction with so many things. I wonder if we're at that point again with 5G. And as you look at something like healthcare, how you see the transition in connectivity that we've been talking about today, how you see that affecting the health industry and our health as people and citizens.
Yeah, I mean, I think, great to connect, Steve. The main issue here is technology is the great enabler, and that's part of the equation. And then also the clinical quality and care that's sitting behind the technology is also critical. And I think both are important components. When you look at the technology itself, I think it certainly is starting to level out more broadly at the foundational level, but we still have gaps in just basic broadband access to the home. So 5G is great for those that have access to it, but I think there's also the gaps and infill that we'll still need as we scale up the technology options, because part of it is the tech, the form factor, in addition to the user itself. But it's certainly a progression forward.
Look, I always try to, when I talk about or think about the healthcare system, look at it realistically. I know there are a lot of positives. We have incredible leaps in our capabilities in terms of diagnosing and in terms of treating people. Cancer is a very good case in how that has changed so dramatically in recent years and the treatment of it. I guess my question to you, and I want our audience to hear the story of Galileo, but I also would want to ask you as an entrepreneur, as someone who's medically astute, if you were to diagnose the U.S. healthcare system as a system and look at what's wrong, what's not right, when I kind of think about the healthcare record system, which I think is pretty awful in America, or I look at the unevenness and the lack of even literacy in certain fields around the nation. When you look at this, I'd just be interested in, from your perspective, what are the things that as an entrepreneur, but also just as someone knowledgeable at this system, are just calling out for fixes?
Yeah, I mean, obviously this is an abbreviated time together, so it would be a while to fully diagnose, all the intricate nuances. At a broad macro level, the healthcare system in the U.S. is, problematic because it's never been explicitly designed as a system, right? It's a patchwork of a lot of different well-intended initiatives, well-intended organizations trying to do things within those constraints. And the reason why maybe people view it much worse than some European countries is it's been, exacerbated by private, subsidies, basically, employers paying excess amount for excess care in a way that's, less coordinated and less value focused, right? And so there's a lot of different elements to unpack, both from a payments architecture perspective, but then also on all the provider muscle that we've built that are really great at specialty care, but perhaps not as great at primary care and preventative care. And then separate from that, how we can then use new technologies much more rapidly through the ecosystem. And the way we make decisions is a multi-layer decision-making process that's slow. So innovation does take longer to percolate through, but each layer has an opportunity to take advantage of technology. So within every layer, you're seeing innovation within the payer side, the provider side, the data side, but not the cohesive stack unless you're a Kaiser otherwise. And so that's where you see some of the dissonance as an end user, like a patient, or as a purchaser of healthcare.
Tell us about Galileo a bit and why you founded it, what problems you're trying to fix, and where Galileo is going to take those people that are members that are your patients. Where is it going to take it in this complex system?
Yeah, I mean, most of my career has been thinking about how do you improve quality and affordability of care. With Hippocrates, it was point of care decision making. One Medical was how do you reimagine primary care. Galileo is really what should the future of healthcare look like if you could redesign it. And it takes, we can all design in a vacuum, but you have to design within the constraints of our current system. So knowing the constraints of our current system, we said, what does a better model look like? How do we make higher quality decisions more scalably against underserved, complex, last mile populations, older patients, using technology in a thoughtful way? And so really it's kind of saying, well, what would you do to reimagine healthcare if you didn't have brick and mortar as an assumption, if you didn't have fee for service as a reimbursement assumption? You still have to work within those frameworks, but we've designed a model that can actually do what we would hope from a modern healthcare system, but much more affordably.
One of the things I've often joked about in my conversations about science, which I'm a strong believer in investment in science and promoting it, is we live in a world where we're on the edge of so many continuing major technological leaps. But if Galileo were alive today, he might still be found guilty. So, maybe your company is going to fix this. But when I sort of think about some of the very provocative things you've said, you've been kind of a no BS guy. If we wanted to fix American healthcare, here are the 5 things that we could do rather rapidly to transform outcomes and transform experience, transform engagement, and people's agency in the healthcare system. Would you share with us those thoughts you have on transformative approaches to the U.S. healthcare system?
Yeah, I mean, I think there's different ways to look at how do you solve some of the healthcare problems. When I was a resident in training, I thought about policy or entrepreneurship. I think they're both possible. I just wanted to be able to shape it within my own destiny, and policy has an important role if policy, has the wherewithal to do so. But in my mind, there's kind of 2 approaches. The incremental approach, which is the most realistic, which in my mind means work within the frameworks, shift towards value-based payments, and what I call keep a relatively stable ecosystem in place so entrepreneurs, innovators can continue to work through the molasses of the healthcare system. It does take some time. The more disruptive, and as I've said before, less politically tenable, is a more radical solution. And this is really just a political will issue. Are we really willing to change reimbursement and payment? And not like at the insurance level, but giving consumers more control of their dollar. And I know, it's a polarizing topic, but I think what we can say is there's a lot of dollars being spent. And if you put more of those dollars in consumer hands, would they be able to spend more wisely? If we then use the dollars more effectively, meaning taxpayers' dollars more effectively to shore up public health, preventive health, primary care, the things that are more classic public goods that don't have really short-term economic incentives. People don't choose to joyously consume preventative health. But if we made it more affordable, same thing with public health, society would benefit. And so by breaking out public and private goods a little bit more explicitly, that would be a radical way to look at it. But, I'm also a realist.
Can I ask you to just go a step further? Because, I've been reading what you've written, and I don't fully understand, to tell you the truth, about first dollar coverage, being in the hands of patients. And I guess as, I talk to lots of folks about healthcare. I talk to lots of patients. We do a lot of forums at the Hill on this. I have always tried to understand as a patient or someone out there in need, how complicated it is to be literate, for that person to have real literacy and understanding the journey they need to go into to understand some of it. So how does first dollar coverage in the patient change the experience for that patient, change their engagement with their healthcare course?
Yeah, the main nuance here is, like, let's take a simple example. The classic one is LASIK, right? It's not a covered benefit. Consumers had to decide something as important as vision on their own to have somebody cut their eye and pay for it out of pocket. But the market addressed that need, right? Because the consumer was paying for that. And so the argument would be, if I'm not super literate and I have diabetes, but I have control of my dollars to manage my diabetes, well, then whoever has those solutions is going to do their best to educate me about the pros and cons. I can pay for that if I need to, right? The person who's a diabetic expert is more open to discussing those things because, again, that dollar is connected to the transaction. And, that's what medicine has been in its old school world, patient to provider. And that dialogue becomes part of the interaction. It's no different than, people learn about, do-it-yourself home kits and whatever. When they're buying it and it's their home, they're highly invested in learning and figuring it out. And the same thing could be true about their health.
Dr. Lee, I've been fascinated during COVID how healthcare provision has changed. We've talked a lot about telehealth in many, many forums we've done here. How, in terms of the new parts of the ecosystem, telehealth, I assume is very much part of your Galileo's delivery as well. How much of that is fragile? How much of that is baked in now permanently? What other kinds of technological advances do you think as we sort of think about our wired world, being connected in ways that we might not have been, say, 5, 6, 7, 8 years ago? And because I hear there's a little bit of concern about fragility in payments, fragility and reimbursability for some of these digital elements that have brought on, that have made people have new avenues to secure healthcare consultations and treatment.
Yeah, I mean, obviously, payment reform and kind of the COVID emergency kind of approval for payments facilitated more digital interactions, and that's been a positive. So people, can try different ways to get care. Galileo is a home intensive and a virtual model. So depending on how complex and sick you are, we may actually see you in the home physical and also digital. So it's a much more modern system where we can see you where and when you might be sick, and whether it's, Medicare, Medicaid, or commercial. We really want to go after last mile populations because they have been traditionally underserved. The transformation during the pandemic was generally positive towards digital health, but that's, when forced to not have any other substitutes, people make those habit changes. But I think in a more normalized world, reimbursement doesn't support necessarily digital. How you reimburse digital is a little bit different, right? It's not the same SKU or unit that you're buying, and those units may or may not be higher volume. So you don't know if you're actually truly reducing total cost of care when you're consuming digital units. And so that's a bit of the challenge, is how do you keep parity with office-based and digital under some type of fixed budget? And I think that's been the challenge, because a lot of digital health tends to add costs to traditional medicine, not necessarily take away costs. And so you have to figure out which portions and what systems actually reduce total cost of care and increase affordability. For us, it's less about the technology, it's more about the clinical care team that sits underneath the technology. The technology is just the bridge. It allows any patient that may not have access to great providers, especially specialty providers if you're in a rural market, to have some of the best access to the highest quality doctors. And we know that quality generally correlates with lower total cost of care and greater patient satisfaction. So if you can level the playing field on access using technology, that's where a lot of the savings yield has the potential. But most of that will need to come through more kind of clear reimbursement guidelines as we start to move forward, because it is the challenge, is reimbursement.
Let me ask you just finally, and I don't know how to get this question right, but I sort of going to try here that, I've read about your partnership with MVP Health and looking at how to reach underserved communities, and how you've got bilingual providers, folks built into this, which we'd love to hear about in a quick moment. But I guess, as we've always talked about, when we talk about reaching people and, being connected, there are a lot of, sections of America. You just talked about rural America, but there are also sections within urban settings that don't have the connectivity that some of us have. I guess from your viewpoint, looking back at the whole country, from your sense, from a real sense of how we're reaching people, how big a deficit do you think is out there on the connectivity side of getting Americans connected in their homes, their workplaces, so that they can have consistent connectivity and consistent health access?
Yeah, it's a great question. I think health equity, which is kind of the broader question, right, is a multidimensional factor and issue. Technology is one of them, but so is health literacy, language access. Just talked. We are launching the Spanish language. We're one of the first digital full stack Spanish language applications to be available and affordable, and this is within a Medicaid cohort. So you kind of have to design it to make it effective and scalable to cover as many gaps. And that's kind of our mission at Galileo, is to cover as many of those gaps as possible. But when you kind of really step back, there are many dimensions to equity and access that are just lacking. Geographic's one, but digital health certainly helps. Digital access is a whole separate issue about broadband availability, particularly in rural communities, and or comfort with digital. So we know that the Medicaid population is relatively comfortable. A lot of them have digital access and or smartphones. That's the work that we've discovered both with MVP and other health plans. But the senior population is less comfortable using app-based technology and are more comfortable using phones. So it really depends on what cohort and segment you're talking about, and making sure that you've got what I call a segment-specific approach to increasing access and, most importantly, affordability. Affordability is probably one of the biggest gap access issues out there. So whenever you can decrease unit prices and decrease total cost of care and or out-of-pocket expenses, we think that that's a generally positive thing for patients.
Well, listen, I always enjoy talking to entrepreneurs in the healthcare space who are particularly focused on dealing with the underserved parts of our community out there. I sort of look at that as the only way we're really going to achieve any genuine equity in this down the road. So I want to thank Dr. Thomas Lee, CEO and founder of Galileo. Thank you so much for sharing your thoughts with us today and for all the stuff you're doing.
I appreciate it. Thanks for having me.